Good morning, folks. My name's Phil Longman. I'm going to be with you for the next 20 minutes talking about some really weird stuff. I want to talk about something that's very strange on hearing. One of the features of working in the health IT world is that there's a lot of us who know a lot about computers. There's a lot of us who know a lot about medicine. A lot of us know something about politics. But very few single individuals have all of those three skill sets, which means that ultimately in this realm that we're in, almost all of us are working beyond our skill sets in one way or another. So when you hear me say some weird stuff, just kind of bear with me. Because there's just a lot of counterintuitive things in medicine in general. I've come to find that it's really necessary to take your preconceived ideas, whatever your ideologies, check it at the door, because it's an upside down world. So my story here starts with the VA, Veterans Administration. And when I say VA hospitals, I figure there's probably still an awful lot of people in America. The first image that comes to mind is this one from that movie from 1989, Born on the 4th of July. Tom Cruise plays a Vietnam vet in a Bronx VA hospital in the 70s. You can see the sample dialogue in there. VA has been a tortured institution for a long time, particularly in the Vietnam era. And so for a lot of us in the healthcare reform world, sort of the last place it would occur to any of us to look for a model of reform. But a strange thing started happening about 5 or 6 years ago, which is healthcare researchers for the first time actually began to apply themselves to defining, first of all, what is quality in healthcare and how do we measure it? And went about rather systematically comparing various health delivery systems and seeing how they stacked up. And the answer that kept coming back made absolutely no sense at all to most of us, because when you apply these metrics like survival rates, patient safety, cost effectiveness, patient satisfaction, it kept coming back that the VA, the new VA, was providing, by many standards, the best care anywhere. So by now, for people who are close to the question of quality revolution in the healthcare delivery system, it's kind of commonly accepted that the VA has become a quality outlier over the last 10 to 15 years. And so it's very interesting for all of us to wonder, well, how in the world did that happen? And it turns out to be an incredibly inspiring story. I think it'll be particularly inspiring to people in the open source world, because it's basically a story about open source before open source was cool, or even there was a concept of open source. When it starts back in the late 70s, when the VA is in really extremis. It's terrible, just as bad as Tom Cruise made it look in that movie. And there emerges a tiny subculture within the VA. A subculture that came to be known eventually as the Hardhats. And these are some of their qualities. These were individual frontline employees who were faced with impossible working conditions and who just tried as best they could to do something on their own to make working at the VA as a doctor or as a nurse or a pharmacist better. And as it happened, this was back in the late 70s, when for the first time, if you had a couple gears in your head and maybe a soldering iron and $5,000 in your pocket, you could go down to Radio Shack and you could buy a little kit to build this thing that eventually came to be known as a personal computer. And they had a few gearhead doctors at the VA who did stuff like that. They went down and got these kits and started playing with them. And one such was a doctor named Dr. Ken Dickey, who in the late 70s running a geriatric ward, VA hospital on Irving Street in Washington, D.C. This was a guy who was in many ways living in the future without knowing it, because The VA at that time had a population that was dominated by aging World War II veterans. They were afflicted with all sorts of complicated chronic diseases. The basic demography of the VA population at that time looked pretty much like the demography of the United States as a whole, as baby boomers now are going into old age. Anyway, he had a hell of a time trying to do his work because he's got all these aging vets in this ward. Nobody knows where their records are. He's spending his whole day running all over the hospital trying to find where's that x-ray, where's that patient record, where's that patient. He gets his hands on one of those old DEC mini computers down in the basement of this hospital, starts hacking away, trying to create what we would today call the first electronic medical record. This, of course, in the day before the internet. They had 300 baud modems. That was about it. His concept was that we'd take one of these DEC mini computers and put it on the side of the ward, and the nurses could go in there and check to see what were the orders for their patients and such. It got ugly. At one point, somebody decided the thing to do with that DEC mini computer, and Ken Dickey, was to set fire to it while he wasn't there. And so they had an arson incident at the VA hospital, and they had to evacuate the whole place. Change is difficult. But he persevered, and not only did he, but a whole bunch of other people who first weren't even quite aware of each other and what they were doing. People like Wally Fort here, who was one of the original Hardhats, who was building early diagnostic tools with these K-Pros and Osbornes and stuff like that. Another guy named George Timpson was very instrumental in this. He talks about how he started using a file sharing program, quite unauthorized, quite unpaid for, that allowed these various different doctors, when they came up with a little program, to basically integrate these programs into something. They got larger, and that's file sharing program was this weird thing called mumps, which this is the Wikipedia entry for mumps. It's an archaic language, but has the great virtue of being relatively easy to learn, and something that even a doc could program in. Now, I want to read you a little quote from one of these hard hats, a guy named Craig Theis, who describes what life was like back in these days when these hard hats were doing their thing. He says, "I spent the whole weekend in Minneapolis sitting right next to the pharmacist. I would program it and try various things, and I would say, 'How does it look?' And he would say, 'Okay, let me check it.' And he would check it and try and give me some ideas, and we would code furiously all weekend and try and get some ideas working to make it work up to speed." Now, some of you might recognize what was going on here. This was people, end users of computing software, being intimately involved in its production, its development. In other words, it was, for all intents and purposes, open source before anybody had a clue. It was software written by doctors for doctors. Now, of course, like many institutions at the time, the VA had a computer division, huge facility in Hines, Illinois, gigantic mainframes with these high priests behind glass doors, and they were working very hard to create a digitalized VA. It was a disaster. In 1976, they couldn't even get the pension checks out on time. The product cycle for health IT was 10 years promised. And so these guys in the VA on the front lines, more and more, just had to take it on themselves to advance their health IT revolution. Now, it was really bad because central office in Washington got wind of this, noticed all these people ordering personal computers. There were congressional investigations about the misuse of property. And so these guys were basically, in many cases, literally had their PCs and mini computers confiscated and put in warehouses. So they resorted to ordering these old Wang word processors that a few of us are old enough to remember. These were basically designed just for word processing. They didn't have any even floppy disk drive on them. So what you would do is requisition one of these things from central office saying that their paperwork was so much that you needed with this thing, and then you would tear the hood off it as soon as it came in and wire it up to a cake tray of silicon and download your your program, and then put it under your trench coat and fly around the country and commit portability, as they talked about it. So this went on for years and years, and eventually some folks, between the failures of the high priests running the mainframes and the continuing sort of underground buzz about this subterranean culture, some of the top brass at the VA came in. There was this storied moment when the head doctor of the VA sort of was invited to come into a room like this and look at all the different software that these Hardhats had come, and noticed that a lot of the machines they were using were ones that he had ordered them to put in their warehouse, and they still had them there. But he nonetheless was impressed and came away saying something like, it looks like there's this underground railroad going on at the VA. And sure enough, that caught fire. So these guys had little cards made up so they could identify themselves when they met surreptitiously, and you knew who you were talking to. Now, this went on for about 10 years, and eventually it got to the point where we had a new director of the Veterans Health Administration who came in, a real change agent named Ken Kaiser, who basically embraced this culture and took them out of the garage and said, you guys now are in charge. And they took what by then was about 18,000 different programs on different applications of health IT, put them together under this big file sharing language, mumps, and created what today is called VistA, which is, by all accounts, the best practices health IT system in the world. No competition at all from anybody who knows anything about this. The VA, just to give you an example of how far ahead they are in the rest of the American healthcare system, it's not just digitalizing paper records. Yeah, that's important. That's a piece of it. The full integration of health IT involves things like this. When you go into a VA hospital, you'll notice a little ritual going on all the time where a nurse will be holding a wand, and the nurse will have a bracelet with a barcode on it. The patient will have a bracelet with a barcode on it. The med will have a barcode on it. She'll scan herself, she'll scan the med, she'll scan the patient. If it's the wrong patient, the wrong med, wrong time, wrong dose, the computer stops her, which is no small thing because, according to the Institute of Medicine, the average American in American hospital experiences one medication error per day, and we lose about 78,000 people a year to medication errors. That particular device was invented by a nurse in Topeka, Kansas, who was returning a rental car one day in 1990. Noticed for the first time that when she pulled in, the guy came out with a wand, scanned her car, gave her her contract. He said, "What the hell was that?" And light bulb goes off in her head. She understands the technology now exists to do this. You cannot find this in more than about 6% of hospitals in the United States outside of the VA. Nor can you find much of any kind of real integrated health IT because you don't have software written by doctors for doctors. Instead, you typically have proprietary software imposed on doctors, and more often than not, resulting in revolt or just passive-aggressive resistance to the actual use of this thing. The other thing that the VA has been able to do with this system, by integrating it so thoroughly into their operations, is to actually advance the science of medicine. One once you've digitalized all electronic medical records, you have, in passing, created a gigantic database of outcomes. And so you can go back after the fact and see what works and what doesn't, whether it's procedures or drugs or whatever. The VA was virtually alone in figuring out the great dangers of Vioxx, a drug that killed more Americans than died in the Vietnam War, after having been on FDA approval for 5 years. How did they do it? Well, their computer systems told them they were having clusters of heart attacks. It's not too much to say that with a few more mouse clicks, you find out what do these people have in common. Seemingly nothing, except the computer will tell you they're all on Vioxx. 45,000 people killed on that drug.
How much earlier did they know?
Pardon?
How much earlier did the VA know?
About 3 years. And they didn't instantly outlaw its use, but they created protocols so if a doctor wanted to prescribe Vioxx, he had to go through all these kind of hoops. Remember, Vioxx was something that was designed for people who had a problem with aspirin. There is a small minority of people for whom it's appropriate, but it's certainly not appropriate as a general population anesthetic. So, VistA has grown and grown and grown within the VA. Now it's migrated outside of the VA. Right now, the whole country of Jordan is busy wiring itself up with VistA. It's an open source, certainly public domain thing. You can practically download it yourself on the internet. You can certainly download the demo. There's a cottage industry of folks who install this. One company, the dominant company in this field is MedSphere. This is taken from their corporate literature. That's their little VW micro van up against one of the big heavies in the proprietary health IT system, Cerner. Now, this would be funny, except that it isn't, because what happened when we passed the stimulus bill about a few years ago is there's $17 billion in there now to encourage healthcare providers to get wired. And most healthcare providers don't know much about computing. Most computing companies don't know much about medicine. So we got a real disaster going on of all kinds of people being mandated to install buggy, ineffective proprietary software. I think it'll be a very common experience in American life 5 years from now that after you've waited 3 hours for your 8-minute appointment with your doctor, he will tell you it's because the damn government made me buy this stupid health IT system. That's how come I've only got 8 minutes for you. I wrote about this in a cover story for the Washington Monthly not long ago, in which I talked about just how evil the proprietary software industry has become. Maybe that's too strong a word, but in any case, we are looking at a system where we're committing as a country and spending billions of dollars to rolling out a health IT system that's going to resulting in data being trapped in all kinds of black boxes with proprietary vendors having all control over it and basically squandering about 90% of the promise of health IT, which is transparency, which is openness. If there's any place in computing where open source more naturally and appropriately applies, it's healthcare. So what is the future of the VA? It took me a long time to get my head around this. I'm not a computer guy. I'm a politics guy, public policy guy. But it kind of clicked to me when Rick Marshall, who's one of the leaders in this world, said to me that you got to understand that VistA is not a particular program, it's a process. And that really is what's key to how come it succeeded. It's written by doctors, for doctors. It's part of a culture that creates a Venn diagram between computing and medicine. It lives in that intersection. And that's why it has had this widespread acceptance in healthcare, whereas the proprietary systems have not. Now, that said, we're talking about a program that's written in mumps, whatever the hell that is, right? Or M, as some people call it. It is archaic. I'm told that Anybody that can learn C can learn M. Doesn't take that long. You can put JavaScripts on top of this. You can do a lot of things. It's kind of an open technical question about where we go from here with a particular code. But before we throw VistA overboard, the code, let's think about this. This is something that's had 30 years of road trial, right? There's no bugs left in it. It's proven. It's proven not just in a VA setting, but we now have very successful installation of VistA into private hospitals such as Midlands Memorial in Texas. Many public clinics are now wiring up. Many people in healthcare have done internships at the VA. Close to 50% of people in medicine have done internships at the VA where they're exposed to this system. They know how it works. They have buy-in to it. It is, I think, arguable at this moment that we have now just expanded access to our healthcare system by 47 million people. We have committed to, at last, having a truly integrated health IT infrastructure. Why in the world don't we just take VistA and make it available everywhere and grow the very vibrant open source community that supports it? That's about it for my time. Most of this can be found in my book, Best Care Anywhere, Why VA Care is Better Than Yours. I can go on for hours and hours if anybody's interested, but I'll leave you right there and hope that's not too weird a story to believe. So thank you very much. Now, I guess we have some time for questions, maybe? Yes.
What do you, sounds like the VistA is really for the inpatient. How does it relate to ambulatory care?
To what?
How does it relate to ambulatory care facilities, your local clinics?
Well, the VA, part of the revolution that happened at the VA was it went from a model that was largely focused on acute care in the hospital, to one that's much more decentralized with clinics out in the neighborhoods. And it's been very strong in doing that. I mean, in fact, that's part of the whole context in which it arose, is the decentralization of the VA itself. Remember that the VA is also unique among healthcare providers in the United States in that it has almost a lifetime relationship with its patients. It starts when they come out of the military. It often extends to long-term nursing home care. Those patients move all over the country and its major territories. So it's very important for the VA to have one integrated system. Now when you come into a VA hospital, your doc, when he opens his laptop, will be able to see your patient records going back to 1986, including scans, all that kind of stuff. It doesn't matter if they were done in Guam or Puerto Rico or St. Louis. It's all integrated. And so this very much lends itself to a decentralized system. Yes, sir?
While it is working towards a decentralized service, would you disagree that it works best in an integrated delivery care network, where all of the pieces, laboratory, pharmacy, are all available and to provide data, and that taking it out of that integrated delivery network, you lose some of the value in that system?
To be sure, but the lesson of that is to integrate healthcare systems outside of the VA. I mean, we got to do it. There are a lot of things said by proprietary software salesmen about VistA. One is it's a legacy system. The other is that point, right? That you can't really apply it outside of a VA system. Well, first of all, it's being done all over the place. It's been done in West Virginia. It's been done in Texas. It's been done. The whole country of Jordan is wiring itself up for VistA. Norway runs on VistA. There's all kinds of countries run on VistA. If you have an integrated, previously existing integrated software or integrated healthcare delivery system, yeah, it's easier, right? But what we have to do in every community in this country is to integrate these various different players who aren't talking to each other. And we could wait another generation waiting for some consensus to emerge around some new proprietary or not software that everybody's going to use. Why not just use VistA? In the back, please. Yes, please.
I think what he was alluding to and what I heard would be interoperability, because if you are healthcare is made of a lot of subsystems being radiology, lab, therapies, and it all feeds into one area, and that's the EMR.
Mm-hmm.
And it's to me, it's wonderful to say, if I'm going to come into a facility, I'm going to wire up all of these entities, and then I'll have one healthcare connected EMR, one fully connected EMR. But that isn't always the case in some facilities. You can't provide that opportunity to wire everything at the same time. So you really need interoperability so that regardless of what radiology system you have, regardless of what lab system you have, regardless how you collect information from the therapies, all that information feeds in to the health record. And I'm thinking that's what he was alluding to with the question that he had. So my question to you, is VistA capable, or does it manage that well? I don't know, I'm not sure.
Yeah, well, there's an interesting project going on in San Diego right now where Kaiser Permanente, which runs on an Epic proprietary system, is involved with the local VA in creating an interoperable platform. And that's great, particularly since a lot of vets get their care at both places. But it squanders so much of the promise, because basically when you've done that, you've replaced the fax machine. So instead of faxing patient records back and forth, you can do it much faster. It's essentially email attachments. And that's nice, that's good, but that's not anywhere near the promise of actually having real integration. So I take your point, and it is possible for the systems that are out there to talk to VistA and vice versa. But since we're now largely looking at a world that is health IT innocent, free in America, right? There's very few electronic medical systems out there. Before we mandate that everybody get it, let's make sure they get the right stuff, and that when they do, it's possible to integrate it truly. So, for instance, the data sharing is possible. In the back?
So your slide about Marshall saying it's a process, not a program, I think that's the best new quote I've seen in a long time about VistA. When you're talking about integration, what's the integration system they use? A lot of people have heard about the open source Connect project. It's going to be the tissue that binds and new integration engine that everybody's going to be adopting and everything else. It was started by the ONC, but most people don't realize it wasn't started by the current generation of the ONC. It was started by the last generation. And guess who ran the ONC when the Connect project was started? It was a card-carrying member of the Underground Railroad. So when we're talking about Connect, when you look at VistA as a process, Connect is a VistA module. It is part of the VistA process. It happens to be developed in Java. It happens to be developed in some way. So we talk about this integration engine. It is VistA. Right?
Yeah.
It is now a competing module for the integration. There's lots of good integration engines inside VistA. And now Connect is a competing VistA implementation started by the same guys, the same community, who did this small off and take it on in the life of its own. But again, if you define VistA as a process, the process by which all open source healthcare occurs, then you realize it's all part of the same thing. And even when it happens with people who are not part of the same group, it's the same ideas.
Mm-hmm.
Right?
Very well put. Thank you. Yes, sir.
Quick question. So what's going on in Washington? You've got your book out, the article. What's happening in Washington in terms of how this is affecting healthcare policy, which is really a mess right now?
Well, there's no effort, at least on the part of the Obama administration right now, to revisit the high-tech bill, which creates this stimulus. But there is a growing panic among people involved in healthcare reform that it's going to end real badly unless we have a really fast reform, not just of health insurance, but of health itself, healthcare itself, the delivery system. When people were trying to sell the bill, you would hear claims like, oh, we're going to see such relief in the emergency rooms because we're going to have all these folks that are now being insured, they won't have to go to the emergency room. Well, we're finding out that's not even remotely true. And worse, that all those St. Elsewhere hospitals out there, the little community hospitals that were praying to God, could we please have a bill where more of our patients would have insurance so we won't have the cost of covering these uninsured patients? Well, be careful what you wish for, because they got that, except that the reimbursement rates are such that they're going to lose money on each patient and be asked to make it up on volume, right? We're already in a world where my wife and I spent 6 months trying to find a primary care physician in Washington, D.C. who's still taking patients. I mean, it's a real breakdown going on already. From now on, everything that goes wrong in healthcare, people will say, well, that's because of Obamacare, right? Not that the thing wasn't broke before. But so I think there is an urgency now and a new receptivity to hearing things about what the VA has to teach us. I'm very involved in efforts right now to roll out what is essentially a civilian VA network that would be a virtual network of these various failing St. Elsewhere hospitals, wired up quickly for VistA under the umbrella of a nonprofit organization that would bring the technical expertise and the political expertise to qualify for the grants that are available to some of these hospitals under the bill. So I think exciting things can happen, are happening real quick, but it's not a question of legislation. It's a question of individual people out there making it happen. Somebody said to me about all of this, he said when the health care bill passed, it's got all kinds of little provisions in it that aren't in the newspaper that really do enable open source health IT, really do enable, in effect, the civilian VA model to roll out. And he said it's like when you're a kid on Christmas Day and you get this present and you open it up and it's exactly the thing you wanted, except it says some assembly required. Right? And that's, I think, where we are. That for those who get it, who get the open source health IT, for those who get the policy side of it, the moment's now. The moment's now. Yes, sir.
Question. What do you think about the dichotomy between healthcare being shared, yet private companies wanting to control their data and not share it for their own profitability? How's that going to pan out?
Well, I mean, I think it's just at odds with the various concept of science and medicine. Right? What is science? But transparency, openness. Where does a proprietary model fit in science? Sorry.
I think we can go on all day, but I'd like to move on to the next
Okay,
presentation.
thank you.